All right, tonight's immunologic emergencies. It's not that much to go over tonight. We're going to hit it, run with it. It's going to be an early night, unfortunately. I'm sure y'all are stoked about it. But kind of dive off deep into this. Let's get my cursor in the right place and get going. We'll go same kind of fundamentals as we always hit every single night. It's just the national EMS education stuff that we have to go over, we have to address, we have to do. These are certain things that we make sure we touch. Um, Immunology is a recognition and management of shock and difficulty breathing. It's related to anaphylactic reactions, and then we'll talk over the anatomy, the physiology, the assessment and management of hypersensitivity disorders and other emergency orders, and also talk about what's like about anaphylactic. Give you some ideas. I'm sure some of you already know details about that, but we're gonna go over it again. So as an EMT, I just really the biggest part of this is I want you to just recognize it, learn what it is, learn what a allergic reaction looks like versus can be mild, medium, or severe. And severe is where here we are with the yawning. I'm sorry, I don't know why I'm yawning, but so the worst case scenario is going to be respiratory arrest and or death. So we want to make sure y'all know how to do that to begin with. Um, but we'll go over acute airway obstructions, cardiovascular collapse. Um, So, biggest thing here is you must be able to treat these with life-threatening complications. You must also be able to distinguish between the body's unusual response to an allergen and an allergic reaction. Today in this chapter, we're going to go over which is the study of the body of the immune system, the immune system, and the 5 categories of stimuli that may provoke allergic reaction. All right, so hold on a second. All right, so uh, anatomy and physiology. So the immune system protects the body from foreign substances, organisms. So what we're going to look at there is when we talk about organisms and the foreign substance that affect the body, it's basically it. Once you get the flu, you've always got parts of the flu in your body, and so let's say you get hit with it again. Well, now you have those immune bodies, the antigens and stuff like that, built up for the next time. Um, they're it's very important. They say the same thing's going to be there about COVID. That's the reason why they want to give you the shot so you can build the immunity and all that. Being positive twice now, I kind of feel like I've got some immunity to it, but I don't know. I really don't want it a third time. Um, but I say that it's there. I'm trying to answer a message at the same time. But so we'll go over those. And when a foreign substance invades the body, we know what happens. Even if you get stung by something, you get a red whelp. It'll swell. That's the body reacting to what's been exposed to it. So it's a toxin really of any type that's exposed to the body, and the body automatically says it doesn't belong here. We're gonna fight it. We got to do something with it. Let's get it out of the way. Um, and it doesn't want it there. So that's the reason why you'll get like fever to the area. Uh, it's you'll have the swelling. You'll notice some other little things that affect it. You know, I've all had ant bites and stuff like that to the area. So going deep into the patho, an allergic reaction is an aggregated immune response to any substance. So what it does is it knows it doesn't belong there. It knows it doesn't need to be there. So everybody in the class obviously can't make it tonight. Hold on a second. Let me message Rob real quick. Hold on, guys. So anyway, we'll keep going while we're waiting because I know ultimately it'll be put on the website. So when we talk about the patho, it's not caused directly by an outside stimulus such as a bite or sting, but we know it's there. Rather, it's caused by the body's immune system, which releases chemicals to combat the stimulus. So that's what's happened. So they stab you with this needle of a bee, because that's what it basically feels like. And what's going to happen is the body responds and releases all this to attack the toxin that's been put into our body. So the body's like, oh, we need to do a chemical dump. Thoom, there it is. Let's fight this toxin that's there. These chemicals include histamines and leukotrienes, both of which contribute to allergic reactions. So we already know the histamines because we take histamines anytime there's an allergic reaction. Benadryl's one, Decadron's one. Those are some of the big ones we know. So those are the ones we automatically take no matter what when we do have a reaction. So we keep that in mind. So given to the right person, the right circumstance, almost any substance can become an allergic reaction. Um, First, the person becomes sensitized, exposed over time to the substance. Then his or her immune system learns to recognize the substance. And when the patient is exposed to the substance again, the allergic reaction occurs. It's just one of those things that happens. That's the body working, which is super cool. It's like latex. We wore latex gloves for years and years and years, and then all of a sudden, bam! People started having so many reactions to it, so many um, just hand swell, and people started having severe cases as breathing. So Rob's answering me about the class. That's the reason why we're having trouble. All right, so Rob's working on that. So we'll keep rocking along. Some patients may not know what is causing an allergic reaction. Those are the ones that you get when they don't know what's going on. They're like, they freak the hell out. They're the ones that are having so I'm trying to message. I can't do two things at one time, y'all. I'm sorry. So that's the thing that's happening is people that don't know what the allergic reactions are. Now I'm back on track, and they're the ones that freak out. They're the ones that call and saying, "Oh my god, oh my god, oh my god, I don't know what's going on, I don't know what's going on," and that's where you get it, and they freak out because it may be something little, and now it's very serious to them because they can't breathe. Oh my god, well, you're not your airway's not shutting down. You're having a reaction to what's going on. So that's where we try to teach in as much as we can. So you have like a mild and local reaction is characterized just by itching and redness and tenderness, which we all know that. Let's say that's just the same thing as an ant bite that people aren't allergic to. And then you have severe and systemic. When you have the severe and the systemic, that's what's called as a anaphylaxis. Sorry, tongue twisted there. All right. So anaphylaxis is an extreme life-threatening allergic reaction. It involves multiple organ systems. In severe cases, it can rapidly result in shock and death. So if you look around here, here's our reaction. And so our B hits us on A. So B, the antigens are coming in right around here. Then we start dropping the C where it says release chemical mediators. So now our body is saying, let's dump this in here. Let's figure out what's going on. So once we get down to D, to the specialized antibodies, we know that. We've seen it. Our body's built up this memory and our CPU of somewhere data space that is, bam, now I know what's going on, but all of these right here can be affected. So we start having severe cases. In severe cases, it can result. Oh, God, dog. I only want to start teaching y'all, period. Um, so in severe cases, this is where people start dying. Uh, Obviously, everybody's having trouble with the meeting site tonight since there's only two of you here. Daryl is here and Alex Jones. All right, well, we're going to keep rocking on. I don't know what's up. So once it gets into the body and it starts messing with things, so all these vessels and organs can have issues. You'll start having skin swellness. You could, in some cases, have edema right in here. You can have vasodilation of the veins, decreased heart output, which we know that because the heart starts pumping faster. And then you can also, in the worst case scenario, have a bronchospasm, and that's where your airway shuts down. So to me, that's just as important as these two right here when they quit working. So I don't like none of that to happen. All right, so here's just a small picture of a reaction. Three common signs: you'll have hives, small area of generalized itching or burning that appears multiple small raised areas of the skin. I'm sure we've all had that at some time, somehow, somewhere. Something has bit us, may not be able to see them or what's going on, but if you're from the south, that right there is mosquitoes, period. That's all mosquitoes. Even on a bad day, they're going to get you. No matter what you got going, burning, holding up to you, that's the mosquitoes. Welcome to the South. So this is kind of getting serious and to severe. So angioedema is localized swelling, and then you can have some wheezing, which we all know is high-pitched whistle sounds that typically heard only on expiration. So she's probably unable to breathe at all by mouth, and she's only breathing in and out of the nose. She is probably having a drooling problem, so we don't want to automatically think, oh my God, that's a toxin that she's been exposed to. Oh my God, we got to figure something out. I'm trying to get Rob on this again. All right. So, and then back to this. So, a highly pitched wheezing, we know about that. And that is a result from bronchospasms, bronchoconstrictions, and increased mucose. So, right here, she's probably got a lot of spit going on, probably out the side. Tongue super dry because it's swollen up and you can't get no spit on there. The high pitched sounds is the bronchospasm, and they're trying to figure out what's going on. They know that there's a toxin that's bothering it, and help me, help me, help me. I don't know what's going on. So on the patho, so you may also note hypotension. So that's we're going to have low blood pressure due to the vasodilation and increased capillary permeability. So what is happening is the vessels are dilated so much that not a lot of blood's going through there. So now your blood pressure is going to drop. We're not going to see a whole lot of the gastrointestinal issues. Now we will see the nausea, vomiting, and abdominal cramps, but you start talking worse times like your stomach's started cramping, and it's called a stomach seizure where your intestines muscles keep firing and all that, but it's not a full blown seizure is what we think for the neuro issue. Whew. But you will see more of the trouble breathing, the vomiting, abdominal cramps. That's about all we're going to see with on a short case. Long term may be different. So big time we start talking about food issues. The most common allergy falling into one of the following five general categories. Food, certain foods will cause them. I don't know where my there it is. Um, these foods can account for about 30% of deaths from anaphylaxis, most commonly in adolescents and young adults. So, prime example, my mom was highly allergic to shellfish, just right there. Couldn't be around it, nothing like that. If she smelt it, she would start swelling. That's what really got me into the paramedicine, is because my mom stopped breathing in one of our towns, and a paramedic came in and saved her life. And as a kid, we're like, I want to do that. So it can take up to 30 minutes. My mom was a quick, she was super, super, so hers would take no more than 5 to 10 minutes, and something had to have been done. She carried multiple EpiPens around, so it was pretty crazy. Um, so you may or may not see the skin hives. So it may be internal. The reaction can be severe and involve the respiratory and or cardiovascular systems. Some medications are the second most common source of the anaphylactic reactions, particularly antibiotics. I'm highly allergic to penicillin. I can't take penicillin because I my whole body starts running a fever. But I don't. I mean, like my head's cool, but my body will get super super hot. Um, most of the time in medications, it's going to take about a 30-minute window. You'll know within 30 minutes. That's the reason why the doctors and all that, when they give you the shot at the doctor's office, they want you to sit there and take the shot and wait 30 minutes in the lobby, make sure that nothing happens. I like how they tell you to go to the lobby, but but hold on, I got to do something for the class. Give me 1 second, y'all. I'm trying to make sure I can get this for everybody. I got to try to send a picture into the Facebook group. All right, 1 second, folks. Almost there. All right, so back to what I was saying. So, medication is going to normally take about 30 minutes, and that's the reason why they put you out in the lobby and make you sit there. What's even funnier, like I say, is that people they put you out in the lobby, and it's funny because nobody comes and checks on you until it's time to go. Well, what happens if you have trouble breathing? Well, I didn't. Nobody would have checked on me. Nobody would have known. So I kind of giggle about that all the time. Um, Reactions to oral medications may take a little bit longer. So if you take something by mouth or what they call PO, that may be something that you may take up to a couple of, like maybe an hour, hour and a half for it to actually take it, take its toll. So calling that in to know, make sure that if you do have a reaction from a medication and or food, note the time on how long it's taken for once they ate it, drank it, or took the medication for the time that they called. That's important to when you go to the hospital, so you can note that time is when you hand it off. So here's some, just that's kind of a worst case of an allergic reaction. You can tell he's had it for a while. A sore spot from itching right there. If the medication is injected, the reaction may be immediate up to 30 minutes, or and severe. Some reactions to oral medications may take more than 30 minutes to appear, but may also be super severe. So this one's been around. You can tell for a minute. Like I was pointing out, that right there, that little spot. I don't know if y'all guys can see it real well. That's really bad from itching, and appears this one right here may have been busted open from that's healing, that may have a scab on there. So plants, poison ivy, screw you, poison ivy, I hate your life. But so that's part of it. So we'll go over that. So, and we're talking about reactions because, and just seasonal allergies and stuff like that is still the same thing, but some people are allergic to like hibiscus plant. That's kind of where we're going. So dust, pollen, and other plant materials can be a rapid and severe reaction. Common plant allergies include ragweed, ryegrass, maple, and oak. Certain chemicals can make up soap, hair dye, latex, and various other substances can cause severe allergic reactions. Latex, like I said a while ago, is of particular concern to healthcare providers. Patients can be sensitive to it. As many as 12% of healthcare providers become sensitive to latex. I didn't, as much as I did, worked in the field. I didn't have that sensitivity. I still don't. Every once in a while, I'll mistakenly get a hold of a pair of latex gloves, and then it catches in my head, oh my God, I need to get these off before I touch somebody that may have a reaction. So that's just something in your head, kind of think. If it looks like a super old box, don't use the old box because it's probably an old box of latex gloves. Some of your common allergies that we see, we deal with, we know what's going on, we have issues. Hey, Rob. Um, is at an injection site, maybe like a honeybee, a wasp, an ant. We know what those are. We know how those appear, what they look like. So I'm sure at one point in time, everybody has had one of these animals bite us, sting us, or do something to us. I think Rob was just checking on us, making sure everybody was able to get in that way. Um, So the reaction can be localized, causing swelling and itching at the site, or it may be a severe systemic reaction. And remember, severe is what we're talking about is, or sorry, the systemic is going to be a anaphylaxis. So remember that. That's kind of your little trigger word, systemic. It involves the entire body, which is going to cause anaphylaxis. Approximately 3% of adults and 1% of children are allergic to the venom of bees, wasps, and hornets. An allergic reaction to insect stings account for 50%, at least 50 deaths in the US per year. And about half of these deaths, the victim had never experienced a reaction prior to stings. So that's your initial. That's one of those that have never, they rookies, um, they never had that issue at all. And bam, got the first one, and they passed away. The ones that they didn't know that they were allergic to it didn't need that EpiPen because there was no way to know what was going on. That's the reason. So that's a very, very low number, and we know that. But again, if you're part of that family that has that 50 death, that's a very high number that needs to be addressed. Um, so the stinging organ of most insects is a small hollow spine. Oh, we know that. Here, look. So this is what we're going to do. We're looking at this piece right here that comes out, that stings, that bites them. Same thing here. It comes out their butts. We all know that about animals. We've learned that throughout time. Uh, because let's see here, if the stinger is not removed, it can continue to inject venom for up to 20 minutes. Because of the flyaway, it is difficult to identify which species is responsible. Wasps and hornets can sting multiple times. They do not die after the stinging. Those little turds. So we know that there's a problem. So I don't like none of them. I want them all gone from my house. Now honeybees, I like your honey, but I'll buy it. I don't want to mess with them. So if you're able to remove the stinger, remove it a multiple times. If you can have to see multiple of them, just so we know that it has quit. If you have a way to put it in like a little medicine jar or something that can hold it and transport it with you to the facility, that's perfect. So they can identify what it is, so they can treat it maybe just a little bit faster and better. That's helpful. That's if, only if. It's not a mandatory thing. Here, this person right here does not like ants anymore. I don't know whose feet these are, but they some hairy feet. Some ants, especially the fire ant, also strikes repeatedly, often injecting a particular irritant into the toxins at the bite site, which I would say I hope all these drowned in the hurricane season is coming up, but we all know that these little turds don't drown. They get in a little ball and they float. So, sorry, I see somebody's message. I'm here. Made it in just to verify. Hopefully everyone else can. Yeah. All right. So Rob's already bounced out. All right. So there's a ant bite. We know that. Pretty sure we've all dealt with that in our entire life. So we know what that is. So here's more of the insect stings, kind of your signs and symptoms. As y'all see right there, sudden pain, swelling, localized heat. Maybe not as much as localized heat because that one to me honestly looks more of a mosquito bite than the other one. I was just kind of being sarcastic. You got redness, itching. Itching possible, you got a raise. So you see here the raised and swollen skin. That's well defined an area of the skin. So something bit him that has injected a irritant to the skin, and that's why you have the swelling. Applying ice sometimes does make the sting a little bit less. Heat will make it worse. Potentially, if there's still the stinger in there, it can release it all. The swelling associated with an insect bite may be dramatic and frightening as long as these manifestations remain localized or not. So if you ever have issues or you worry about a bite, take a pen and outline the furthermost point, and in 10 minutes check it again. If it's swollen out past that point, then that's something that you may need to seek medical treatment over and have be checked on, because that area is swelling drastically. And that's what we do. And I mean, anytime, that's what I was taught. If you see a bite, maybe let's say like a snake bite or anything like that, you mark the outsides of it, and then so that gives you your timing. Is anybody else having trouble hearing me, or is everything good to everybody else hears me well? Robin, is it just you? Daryl, can you still hear me? Oh, okay. All right, good deal. Had to make sure. All right. Had me worried for a second. All right. So insect stings, and so we're talking about more of your anaphylactic issues. So all of these are going to be very predominant in your anaphylaxis. Um, Worst case, I don't know if it talks about it later on. Yeah, it's in the next slide. But so your gastro and complaints is going to be your nausea, vomiting. There it is up there. Chest tightness. You're 90% of the time going to have shortness of breath. So once you get your shortness of breath addressed, because that's something you can fix right then, right there. Get that handled at first. Uh, Uh, so get those situated. Treat your hypotension if you can. If you need to put them in like in a Trendelenburg position because you're worried about the hypotension, that's fine. Dyspnea, it's 1 or 2 word dyspnea. If you have the issues of the chest tightness and coughing, you can fix these, potentially fix them with just applying some oxygen. Anxiety, that's going to freak them out. Comfort care is probably your best thing that you can do at this point, and just tell them, look, we're doing everything we can. Take a deep breath, try to relax. Stuff like that will be very helpful. So occasionally respiratory failure, if untreated, an anaphylactic reaction can produce rapid death. That's the worst case scenario. We don't ever want that to happen. More than 2/3 of the patients who die of anaphylaxis do so within the first 30 minutes. So rapid treatment and transport is very essential. So the faster we recognize it, the faster we treat it, and the faster we move them to ALS care and or a medical facility, the better chances of survival that they have. So patient assessment in an immunologic emergency, size the scene. If the patient is still being stung by a swarm of bees, wasps, don't take your butt up in there. Just I don't care if you've never had a reaction before. Don't go up in there. You just call for some backup. Fire department, spray some water in the area. It's not your problem until the scene is safe and you can get in there. Check the area. If you're at a seafood restaurant, somebody's never had issues with seafood, you can probably much guess what they're exposed to, okay? And say that you probably noticed their exposure was to seafood. Maybe those king crab legs got them. I don't know. So the new medication is not uncommon. That has happened a lot more in your elderly because of new medicines that are out and about. Some of the elderly are not used to these new medicines or haven't had the exposure to them, so they're more sensitive to the medicines that are out there, and that's why that you may see it more in a elderly area. But again, somebody's like, oh, well, you're not allergic to the lab made penicillin. No, cuz I'm allergic to it all. I know because I quit breathing. So to me, that's very important. I don't want to do that. So that's where you're going to see your new medication. And if that's the case, take that medication with you. Document all of our findings. We already know is who, what, when, where, and why when they took it, why they took it, who gave it to them, how long they've had it. Is this the first dose or the fifth dose of this medication? That's going to help you with your report. Uh, A respiratory problem reported by dispatch may be allergic reaction. Keep that in mind. Don't always just assume that uh, the shortness of breath is because they were walking. Um, but until a field impression or allergic reaction is firmly established, be mindful of other potential causes of respiratory distress. So there may be something else that's causing this problem. But let's keep our mind open. Let's not We want to stick to our gut feeling and what this person looks like, but at the same time be open to change and that saying, well, maybe this person does look like crap because of this reason. Well, if I can just put them on some oxygen, maybe they won't look so crappy. Y'all know what I'm talking about? Um, Follow the standard precautions with a minimum. We know that. Considered ALS. Most of the time, if you're on a BLS truck and you know that you're going to a shortness of breath or allergic reaction, ALS should go with you at a minimum. If they don't, request one as soon as possible. Maybe they're tied up on another call or they are far away, but build a good enough report so you can give to your medic either by phone and or radio as fast as you can. That will help them out the best that they can. So quickly assess and identify immediate and potential life threats. We know, stop, fix it, you're good to go. If we can fix it, the better off this patient is. We know that things are going to work. So look for medical tags. Medical tags are still good. A lot of people still wear dog tags. I mean, that's one of the things. Check their dog tags. Let's see what my notes over here say. Patients experiencing severe allergic reaction will often appear very anxious. If your general impression finds the person is anxious and in distress, immediately call for ALS backup or assistance. I like that word a lot better. Um, that's the most important thing is if you know that you need help, call for it early. Don't wait to the end and be like, oh, well, we need them. We're transporting. We need them. If you walk in and be like, ooh, I need some help, call for your help now. Um, Airway and breathing. If we know we can fix it, let's fix it. If we can't, need somebody higher than us, guess what? We need somebody higher than us. Anaphylaxis can cause rapid swelling to the upper airway. It can close the airway, so that's something if an ALS provider gets there and they need to tube this person, they may only have one chance because once you insert the tube, you can inflame the airway and cause it be a little bit more hard of an area. If you haven't already tried to sedate the patient, that may be a problem that you're going to have to worry about down the road when you should be trying to put a tube in the patient's airway, but you waited too long. Um, you may only have a few minutes to assess. Oh, we talked about that. So not all allergic reactions are anaphylaxis reactions. Work as fast as you can to assess the patient to determine the severity and symptoms of the number of body systems affected. So if you're just having an airway and it's not cardiac, we can work on that. We can fix that. But if you're having airway and cardiac problems, you know that you're going to need some more help. Not saying that you can't handle it if you're going to A school or if you're just out there on a BLS ambulance, you know that you're going to need ALS assistance. So get as much information as you can, do a quick assessment, and call the ALS care as fast as you can. We're going to continue increasing. We know that these signs are signs that we see when they're having respiratory distress because we talked about these in prior class. The head bobbing, not real sure if they're just agreeing with you or what the deal is, but I know we talked about the tripod position. Nasal flaring is not from you trying to put 15 liters through the nasal cannula, but it actually because they're trying to suck in as much air as possible, and it's just not working. Use of accessory muscles. What we mean by that is called the seesaw method in younger kids, because younger kids don't normally have as big of bellies as us as adults. But it's when the chest goes out, the stomach goes in. Stomach goes out, chest goes in. So they're using their stomach muscles to help them breathe. So that's what we mean by that. So let's see here. Stridor, a harsh, high-pitched sound heard in inspiration, can eventually lead to a total airway obstruction. The patient may eventually fatigue and even stop breathing. In later case, cardiac arrest will shortly follow. Somebody tell me why from that cardiac arrest is going to fall secondary. I don't know if maybe my question didn't make it out right. So what I'm asking is if the if the patient starts to have respiratory distress, why are they going to eventually go into cardiac arrest? Well, what I'm asking and saying is they're going to go into cardiac arrest because of respiratory arrest. They will eventually go from respiratory distress to respiratory arrest, and then that right there is their cause of the cardiac arrest. So we all kind of bounce off each other. Go into respiratory distress, you start getting worse, you're going to go into arrest, and then the heart doesn't have any oxygen, so now it's going to quit bleeding. So that's where we're at on that. So the airway, assess the patient's airway and make sure the patient's in a comfortable position. Generally, they're going to be, well, it says right there in a high Fowler's position. Basically, it's a seated, lean back position. So if somebody's driving 6 hours down the road and you're the passenger, you're going to try to lean back a little bit. You're going to get comfortable. That's the same way that you want to try to transport a patient in the most comfortable position that you can, and that's the semi-Fowler's. What that does is it helps maximize the ventilations because it doesn't put stress on the chest. Kind of gives them an angle where they can relax a little bit, so they're not having to worry about their accessory muscles and all that fun stuff. I'm sorry, I don't know if y'all heard that, but let's get rid of that. So if the signs of shock start to take place, that's where you need to automatically drop your patient into supine position, get them ready. Um, for possibly a OPA, NPA, and for ALS assessment to come in and help you back there. But you know at this point that if they're going into shock that they need some higher level of care. So hopefully you're trying to intervene with your ALS provider. Um, Always, and I don't like how it says don't hesitate to initiate high flow. Always give them oxygen. I don't matter if it's nasal cannula, a non-rebreather, or you're having to bag them. On every call, they should be on oxygen. I don't care if their respiration rate are 98%. At some point in time, you're gonna need to check pulse ox, and if it's a little low, you already got O2 on them. And it's super cheap, and you're automatically providing a care for somebody that needs it and they don't need it because good oxygen is always good for you. For a patient in severe respiratory distress, you may have to assess with ventilations using the bag valve mask. We just talked about that, so I'll have to read my notes on that again. But it's very helpful if you're already giving it and then you got to break the bag valve mask out. If you got them on a nasal cannula and you got two O2 ports in your truck, just leave it. Leave them hooked up to that. And then put the bag valve mask on top of it. It'll help you. Every little bit helps. Y'all remember that. When you're checking your circulation, some patients in anaphylaxis may present with signs and symptoms of circulatory distress, such as hypotension. So remember, if you got them flat to their back and you realize that they're in hypotensive and they got that low blood pressure, well, if you elevate them just a little bit or you put their feet up just a little bit, maybe that will help you. Now, you don't want them with their feet and head up at the same time. You got to figure out which one you want more important. But if you feel that you can't fix it with them being in the Fowler's position, say, listen, I'm gonna lower you down for a second. I'm gonna raise your feet up a second. I want to get your blood pressure a little bit better than what it is. Don't tell them it's crap over crap, but just fix it the best that you can. You always check your vital signs. This will be checked in your primary assessment, secondary assessment, your ongoing assessment. Look at them. Look, are they cyanotic? If they're blue or they red, do they look like they sweating their butts off? You should already know this right here with a delayed cap refill because of the pulse ox. So that shouldn't have to be their cap refill is delayed because they're oxygen deficient. If you check their cap refill and something's a little low on that, then let's fix it. We know the hyperperfusion is because they're not pushing enough blood out the heart. Why? Well, we don't know, but we're trying to fix that, okay? Could be because of this anaphylactic or severe reaction that they're having to wasp stings. So do your best, take a deep breath, and work this thing out. Some of your treatments, simple, very simple. Oxygen, positioning them in the right amount, and don't let them lose heat. If it's winter, keep them covered. Summer, they can go into hypothermia in the summer too because their body's muscles are quivering so much that they're losing the heat. So be careful when you expose them in the summertime because they can go into hypotherapy, or hyperic. So be cautious of that. Definitive treatment for anaphylactic shock is epi. If you have EpiPens, if the patient has an EpiPen and it's theirs, you can assist them in giving that EpiPen and or giving it to them because they're unable to, but you've noted it's the correct medication, correct dosage, into the correct patient. So those are some very important things that you need to check when you go to give that medicine. So, but if you got to have Epi in as fast as you can and in so they can come out of this reaction a lot better than so that we know what's going to end up happening. We talked about transport decisions. We know that's really over and over and over. We know. Transport to the most appropriate place, to the most appropriate facility, and as fast as we can if needed be. Investigate. What they mean by investigate is the chief complaint. Is it the right chief complaint for the right is it the chief complaint for the right illness and the history of the present illness and the chief complaint match? If they're completely off, they're like, oh, well, I'm just having trouble breathing, but my left toe is what I called you for. Wait, what? So like you're both complaining or what? So any signs and symptoms, take notes, helps us build our report, does for documentation. The first time you actually sit down to do a documentation report, it's probably going to take you a hot minute, and it'll look like crap until you've perfected it over time and your PCRs get better. So here's a chart that should be in your book on history taking. Some of the questions you can look for that will tell you which body symptom is affected. This is a pretty cool little chart. I like how it's broken down and tells you versus respiratory, cardiovascular, skin, and other findings. Two seconds. I want to look at something. All right. So we know our sample. We should. Everybody here should know your sample assessments. Make sure that you know them. Start memorizing them during the boot camp. If I'm able to make it, I'm hoping that I am. And I will hammer you guys on this. Make sure you know your sample, what it means, how it means, forwards, backwards, front, and upside down. I'm spitting. I ain't gonna be that mean. Be on alert for any statements regarding ingestion of foods that cause allergic reaction, recent shots, recent medicine change, anything like that. If they said they had nausea, vomiting in the past couple of days, but it went away when they went to sleep, when they woke up and took their normal dose of medicines, it just came back, trigger information right there. So your secondary assessment, we know these. If you gave oxygen for the stridor or the wheezing and it got better, we better note it. First off, let's note that we did that and that it's improved because you're going to go back over and reassess that and redocument that treatment once you're done with this call. Remove any clothing necessary to look for the presence of a bee sting, signs of contact with chemicals, and other clues, suggestions of a reaction. Look for obviously the medical alert tag. If you've not already done so, auscultate for breath sounds. I want you to listen. Get close to them. Get up there and listen with your stethoscope. The super cool ones that you bought for all your ride-alongs. You want to listen for the wheezing or the stridor and inspect the skin. We know that's important. If systematic reaction continues, the body will have difficulty supplying blood and oxygen to vital organs, and an altered mental status is one of the first signs that you're going to notice. So your patient may change in front of you. You may be carrying on a conversation with them, and all of a sudden you'll be like, wait, what? We just talked about this. So that's your altered mental status that you're looking for. Yo, I'm telling you, I have not yawned all day long until I sit down and start talking to y'all. Doesn't matter which computer screen I'm looking off of, reading off of, and making sure that my notes match what the screen shows. I'm always yawning. I don't know why I'm yawning. So y'all, I'm so sorry about that. Um, Again, you're doing your second baseline of assessments. I mean, your vital signs, sorry, and that could be Q5, Q10 because could be stable or non-stable patient, and you need to check that status in whatever position, whatever status that your patient's in, and make sure to. I'm telling you, your times are going to be off because you didn't do it at the right time. Crap, I just thought about that. But you need to know how often you're supposed to do them in because that's very important. Not 10 and 15, but 5 and 10. So what's that say? Patient pulse ox. We know check your pulse ox. It's always easy to leave them on if you have a LifePak 12. Some of your other machines, I don't have a lot of history and information with. 12s and 15s are kind of my go-tos. But they monitor your pulse all the time. The pulse ox, if they get too low, they'll tell you. They start beeping. Trust me. Um, on your decision making on when to apply oxygen, when not to apply oxygen, depending upon what the patient looks like. If the patient looks like they're having trouble breathing or they're working to take breaths and you don't put them on oxygen, you in trouble because that's neglect. Do it. As much as don't just wait on what the pulse ox says. If the pulse ox says that it's below a certain number, you don't need to give it. You you need to come back to me and we'll talk about this again. But if the patient is struggling when you look at them, go ahead and put them on 15 liters and then go for your tools that's in your tool bag to use to treat a patient. Um, Repeat the primary assessment as much as possible. If you always said Q5, 510, we already talked about that. We're gonna skip that one. Any interventions? If you did something, check it, reassess it, redocument it. Um, Let the facility know, hey, EpiPen was given at 17:15. By 17:45, patient was awake and alert. Had a little trouble with shortness of breath. Vitals are, see you in 15 minutes. Something like that. So document the change of anything right here. Um, Communications, so we know about that. Patient's response to the treatment. If they get better, they get better. If they get worse, they get worse. You need to document the changes here and why you chose what care that you did because you recognize they were going into allergic reaction due to da 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 da. At this given time, patient stated that they had a EpiPen, right person, right dose, right time, right location was all not noted, and Epi was given at such and such time by IM to right leg. That's just a little synopsis of what I would put in my report. If a patient appears to be having severe reaction, administer BLS care, provided transport to the hospital. It's one of those load and goes. Let's hurry up and go. I don't want to have to wait any longer because I don't want to have to work a code. So let's get moving. All right, so we're going to go over here's how to remove a stinger if you can. If a stinger is present, scrape the skin with the edge of a sharp, stiff object such as a credit card. Don't use tweezers or forceps because what will happen is you'll actually try to push it deeper into the skin. So what it is kind of like using that credit card to pop the pimple out of their arm from the stinger. That's really all that is trying to do. That's the breakdown of it. Wash the area, keep it clean. It's still it's an open wound, so that's why we want to clean it. If you have to remove any jewelry, make sure you give it to a family member and/or put it in the patient's pocket. I can tell you, don't set it on the bench or the workstation, because a couple hours later, the hospital calling you back and be like, "Hey, did you happen to see such and such's watch?" And you're like, "Oh, yes, I did." So then you look like an idiot, like you're trying to steal it or something. So be careful about that. Um, the reason why they're telling you to position the sting below the heart is because we know. I mean, it pumps. If it's above, if it's the arm and they're holding the arm up, the toxins or the chemicals going to flow straight downstream. If it's hard for if you're holding it below the heart, it's very hard to pump it uphill. Which we all know that same thing goes with water and wind and all that fun stuff. But keep it below. If you have to apply ice or cold packs, feel free. We don't teach you about the home remedies, the Copenhagen wet or dry, or the long leaf wintergreen snow cut cuff. You can tell I don't dip, so I don't know. But we're not going over that because those are home remedies. Not saying that they don't work, but we're not gonna talk about it. Here's some of the signs and symptoms. Be alert for us. Be alert for airway swelling. If they start to have some trouble breathing, or they say that my throat's closing in. That's one of your telltale signs right there. Something's going on. Place the patient in a supine position indicated and give oxygen as needed, and monitor the patient's vital signs and be prepared to provide further support as needed. Because now that mild or moderate allergic reaction is starting to become severe because things are starting to swell and close. Epi, we know we talked about that, what it does. Um, Epi is a systemic response, and it's the fight or flight. We know, like when things happen in traumatic events, we scare us. We get that dump of Epi, we get the fight or flight, like shit, I gotta go or shit, I gotta fight. So it's one of those that drops it. But Epi is very good. It bumps the blood pressure. I mean, it bumps the pulse rate up, gets everything going, and it helps fight against that toxin. It has various properties that cause the blood vessels to constrict, which reverse vasodilation and hypotensive. Right there, we talked about the increased cardio output, and it helps with the bronchospasms because now it's instead of freaking out and spasming, it is everything is slow and it's starting to help close out the spasm. Um, it does rapidly reduce and reverse some of the effects of anaphylaxis. It does help. That's the reason why we want you to hurry up and get it in as fast as we can, as soon as we can, and that helps us out the best. Um, so that's the reason why we want to shoot for the EpiPen. If they don't have EpiPens, ALS providers do carry it. And sorry, my kid's texting me. So here's breaking down Epi. You got to have it prescribed by a physician, and it comes in a pre-dose. Some of y'all may carry EpiPens, some of you may not. If you've probably seen one, be careful. They are ungodly expensive. Your EMS service may allow you to assist the patient's administration, but again, refer to what your local protocols say. If your local protocols say that a BLS provider cannot do it, then you get in line for the ALS provider to get there, bro. That's the best I could tell you. I don't know. Certain protocols allow certain things. Certain parts of the country allow you to do different things. There's an EpiPen. That's what it looks like. This is kind of important. So the dosages gives you 0.3 milligrams of Epi. For an infant system, it delivers 0.15, which is it breaks it down and helps things out. So these are all pre-filled, pre-dosed. You don't have to worry about that. Let me read you some of my notes here. The medication has expired or discolored. Do not give the medication. Inform med control and continue to provide emergency transport. Epi can have an effect within 1 minute, so it is the primary way to save life if someone with a severe anaphylactic reaction. Because Epi constricts blood flow, it may cause the patient's blood pressure to rise significantly. That's okay. But if it's helping them breathe, and yeah, I'm cool with that. I'm all right. Y'all kind of feel me. Let's get that epi in there. Their blood pressure goes up a little bit. Sure, I can handle that. Let's just make them breathe. That's the best part. Breathing is the winning game. Some side effects of epi are all the ones that are listed above, and y'all can assume why. Um, Everything's increased. You notice that? Everything. High blood pressure, increased pulse rate, anxiety, cardiac arrhythmias. The cardiac arrhythmia is probably going to be sinus tach. I'm going to say borderline, very borderline. SVT, which is centrifugal venturi tachycardia. Blah, 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 blah. So that's pretty big there. Chest pains because they feel like their heart's beating out of their chest because of the increased pulse rate, the blood pressure. Headache because of the high blood pressure. Vomiting and nausea fall hand in hand right here. Sometimes with the dizziness or the cardiac rhythms will make them feel like crap, and they'll just kind of drop. So that's the biggest thing right there on that one. And emergency medical care. Do not give epi to patients without signs and symptoms of respiratory compromise or hypotensive. Those who do not meet the criteria for diagnosis of anaphylaxis. Um, just as a telltale, so you'll know kind of on the side, um, epi so epi right here has to be given IM, which is intermuscular. So it's got to be given into a big muscle like a thigh, um, the buttocks. The thigh is the best place to give epi. It shows, if you can see this little picture, that's the leg right there. High in the leg, kind of upper thigh. That right there would probably be right waistline. You can see on my little marker moving around. And you basically just kind of jab it into the leg. And don't put your finger over the end. Sometimes it can have a reaction. That finger can blow. The spring on the end can blow out. It's not like it's super, super dangerous, but it hurts you. And then the spring injects the needle pretty quick through here. It can go through clothing, at least. I know a pair of a good size insulated Carhartts it'll go through because I've used it through one. Now I'm gonna go back to my slide. So epi also with epi IM, it must be a concentrate of 1 to 1,000 is what they're looking for. So epi comes in 1 to 1,000, 1 to 10,000, but you give epi IM with 1 to 1,000 is the most important thing. But you need to figure out what your protocols are going to allow you to do, or if they even allow you to do any of that. So that's kind of the big thing is know your protocols, know what your local area is going to approve for you to do as basics, and make sure you don't forget that. Does anybody have any questions? I see it's the top of the hour. I know there's only 8 of y'all. We've had some issues getting in tonight. Does anybody have any problems, concerns, complaints, or anything that I could potentially fix right now? No questions. Robin, I know you ready to go too. I can feel it, baby. Don't worry. Um, so I don't know, only 2 of y'all probably only heard me in the beginning that this class was super short. I think it was supposed to be put with another lecture, but I'm not going to teach another lecture that would put us ahead of things. I would rather just cut you short tonight and get you out of here. That's just me personally. So that's it for tonight, to be honest. Um, I know that I can go over a few things if you guys would like. Want to talk about anything in the past classes? Super cool. Or we can just kind of give you your code and let me know how you do on your test. We'll go from there. Let me try to see if this will let me type. Stand by. I don't know why it does this to me every time. I know, Robin. I touched everything that the slides that we cover, that we go over. That says everything that I'm supposed to talk to y'all about. And why is it not allowing me to see my cursor? So I'm gonna say the code very slow. If somebody can do me a favor and type it in there. Hold on, I gotta type it out real quick for myself. All right. Robin, if you don't mind, if you're able to text, I would appreciate if you can just write this in the code for me. But your code for the class tonight is Tango T1 F as in Foxtrot 2 Y as in Young. So it should be T1 F 2 Y. Thank you, Robin. Listen, guys, it's gonna take for a little while. I have to take care of something else. I just realized, even though class was short of. So you may not get to see the class to sign in or anything like that till like 8:30. So give me a little bit, and then I'll get over to Rob. And then for some of the ones that missed the beginning, if you want to log in and see on the YouTube, the video should be up a little bit later too, and we'll get that all taken care of. If no other questions, I know it was super short. I don't know what else to tell you, but y'all have a great night. And the class code is correct. Tango 1 Foxtrot 2 Y. T1F 2Y. Thanks, folks. Y'all have a good night.